Uh, it's my pleasure to introduce the first presenter today, Dr. Norio Ohmagari, Director of Disease Control and Prevention Center, National Center for Global Health and Medicine in Japan. His talk is entitled Response to COVID-19 in Japan.
Dr. Kui,
Please,
thank
Dr.
you.
Ohmagari.
Oh, sorry for that. Dr. Kui, thank you for your kind, introduction. Thank you so much. And I'd like to thanks to all the people who are associated with this VANJ 2020 for inviting me. And thank you so much. So anyway, let me start my presentation. Okay. Okay. So then let's see. Okay. So it's coming. So am I sharing my presentation window?
Yes, very
Okay.
clearly. Thank you.
Okay, thank you so much. Okay, so let me go ahead. Excuse me. Let's see. Let me just keep my time. Alrighty. Okay. So again, my name is Norio Magali, working at National Center for Global Health and Medicine, which is located in Shinjuku, Tokyo, Japan. And this is one of the national center, and we one of the strong point of this NCDM is clinical management of infectious diseases. So for that reason, I've been involved in the clinical management of COVID-19 and also research and development activity against COVID-19. So today, I'd like to take this opportunity to explain what is the response to COVID-19 here in Japan. So let me start with this picture. This is a picture taken in January, in the end of January. At that time, what happened is there was an outbreak of COVID-19 in Wuhan, China. And there was a lot of people associated with Japan living in India. So the government of Japan sent a special airplane for the evacuation of those evacuees from the Wuhan for 6 times. So this is actually first flight from the Wuhan to Haneda International Airport. And we, the people at NCGM, has accommodated all the passengers coming back from Wuhan. And we did a screening for COVID-19, including meticulous, history taking and also PCR testing. And actually, I believe 1.7% of the passengers came back from the from the Wuhan was positive for COVID-19, including the more than a couple of asymptomatic patients. So this is the very first, exposure from us, Japanese doctors, to the COVID-19. And the next wave came to early in February. That was the, so to speak, diamond princess. This is a very big cruise ship, and 1,000 of people were having travel on board on this diamond princess. And there was a cluster, very large cluster of COVID-19 within this diamond princess, which created more than 700 PCR positive cases of COVID-19. And we, the healthcare personnel in Tokyo and the Tokyo metropolitan area, and also other block parts of Japan, had to accommodate all the patients who are positive for COVID-19. And honestly speaking, that was a quite very hard time for us, for the healthcare personnel in Japan. That was like, response to disaster, like a very big earthquake. It took 1 month for us to, go through all of the this process to cope with what happened in COVID-19, what happened in the diamond places. But anyway, we've gone through that. Although it was a very hard time for us, however, we had a bunch of experience through taking care of the patients who were coming down to on the ground from the diamond places. So afterwards, on the March, in the last half of March, the first big wave of COVID-19 started in Japan. And now we are in the middle of the beginning. I hope, it's not the beginning, but we are in the third wave of the COVID-19 here in Japan. So let me start what the characteristics of the cases of COVID-19 here in Japan. To do that, we are utilizing this registry, the COVID-19 registry. This is the database for all the inpatients, almost all the inpatients of COVID-19 here in Japan. although doctors are quite busy, however, they are taking their precious time to, input those patient data into our electronic database to create this platform, I mean, the registry. So this is a precious database. So I'd like to introduce some of the results of the epidemiological study through this registry. So this is the comorbidity and the severity of the association of the comorbidities and the severity of the COVID-19. From the left side, I'm showing all the personnel, patients who needed no oxygen and who needed oxygen, their intubation. And in the left side column, I'm showing the major comorbidity that is associated with the severity of COVID-19. And what happened to be seen was those comorbidity, especially the obesity like diabetes, which are quite notorious for the very strong risk factor for severe COVID-19. In terms of the prevalence in Japan, that was quite low. Um, um, Compared to the number of the UK and the US. So it said that in general, the mortality of the patients is COVID-19 here in Japan is lower to those number in the country from Europe and northern and the southern part of America. And we made a hypothesis that that might be at least partly explained by this low incidence of obesity and diabetes, low prevalence. Low prevalence of obesity and diabetes in the population in Japan. This is the actual picture of my patient, my sickest patient, who is a 63 years old male who came from from US by a Diamond Princess, who developed very bad pneumonia by COVID-19, which necessitated um, intensive care. On the day 7 from the onset of the symptom, he needed, mechanical ventilation. But as we couldn't keep on his respiratory status even on the mechanical ventilation, we utilized ECMO, extracorporeal membranous oxygenation, to save him. Actually, it took 1 month to wean the ventilator off from this patient. But anyway, we weaned off him from the ventilator. And actually, it took 2 months for him for the rehab, because after 1 month of the mechanical ventilation, his muscle was quite weak, which necessitated long-time rehabilitation. However, finally, he went back home. So this is although the fraction of these sick patients is quite small, however, it does happen. So now we know that most of the patients, almost 80%, more than 80% of the patients with COVID-19 is almost asymptomatic or having quite mild symptoms like a common cold. However, like 2 or 3% of the patients will develop quite severe COVID-19, which necessitate this kind of quite invasive treatment. So this is a quite notorious and a quite characteristic part of the COVID-19, which we have to keep in our mind. Well, another issue is, so to speak, long COVID, long-time consequence of COVID-19, which was started to be reported in Italy and in the country of in the Europe. But now, although the size is small, a couple of studies in Japan had shown that we in Japan also had a similar problem. We NCCV have a very common, a small cohort of the patients whom we are following at the outpatient. So we followed the 63 patients on the outpatient clinic of NCCM, and we found that the incidence of a cough and dysuria, dysomnia, dyspnea, fatigue, and sputum is quite high, and it lasted more than 100 days. So it is apparent that the patients who had COVID-19, although may have quite a mild symptom, but they develop this kind of long-term consequence, so to speak, long COVID. Although we don't know for sure what is the magnitude of the issue of COVID, long COVID, however, it might be very big. The other thing is we don't know the detail of long COVID. For example, I had one patient who developed the aortitis, inflammation of the aorta, abdominal aorta, which resolved within a week, which is, I don't know why it happened. The overinflammation that was provoked by the infection by SARS-CoV-2 itself may cause this kind of the overinflammation in the aorta, but we don't know for sure what is the mechanism behind that. To know that, we have to keep going on doing this kind of the epidemiological study to find out what is the incidence, prevalence, and also mechanisms of or behind the COVID-19, long COVID. I'm sorry. Okay. So this is another data from our small cohort. We found that almost 20% of the patients of the COVID-19 eventually develop alopecia, hair loss. It is quite surprising. This is another data from our COVID registry. So basically, this is what kind of the waves we have experienced in the last 10 months. On the left side, we see the peak. This is the first wave in Japan, and on the right side, we see the second wave in Japan. The pink bar shows the severe case, and obviously, it seems that on the second wave compared to the first wave, we have experienced a smaller number of the severe cases of COVID-19 here in Japan. And I believe that this kind of a phenomenon, trend to weaker diseases, milder diseases, has been seen in other parts of the world as well. And what we have noticed is the time from the onset of the symptom to diagnosis or admission has decreased significantly. In the first wave, it took 7 days for the patient to be admitted after the onset of the symptom. But now in the second wave, it took 4 days for the patient to be admitted to the hospital or after the onset of the symptoms. So shorter, time from the onset of the symptom to admission may, improve the outcome of the patients with COVID-19. And what we have witnessed through this COVID regi is the, improvement in the severity of the patient with COVID-19 between the first wave and second wave. So the left side is the first wave. Oh, let me just, okay. Okay, so let's start with the first wave, and the right side of the second wave. And I'm sorry, somewhere in Japanese, but we stratified the data into the age classification. So let's see the patient at the age of 70 or older. So the percentage of a severe case was 48.4% in the first wave. However, it decreased to 30.6% in the second wave. So the severity seems to be milder compared to the first wave in the second wave. And which is also true in the mortality of the patient. On the left-hand side, we see the first wave. On the right-hand side, we see the second wave. And we are just seeing the patients with severe diseases. And we stratified the data into the age classification. So talking about at the age of the 50s to 69, the mortality decreased from 10.9% to 1.4%. This is quite surprising. And on the column of 70s or older, the mortality decreased from 31.2% to 20.8%, which is also decreased. So we don't know for sure what caused this decreased mortality in the patient, but improved medical care or the improved access to the test for the COVID-19, or could be the change in the virus, mutation of the virus may explain for that. We don't know sure for what is the exact reason for it, but anyway, the mortality is decreasing in number, even though we have stratified the data by age group. Talking about treatment, we are thinking about 3 aspects of treatment. First one is antiviral, the treatment for virus. Well, by suppressing the growth of the virus, we can treat the patient. I mean, we can heal the patient earlier, and we can probably prevent the the exaggeration and exacerbation of a patient with COVID-19. But in some cases, probably they have a very big number of the virus in the body, which cause the dysfunction of the immune system, which causes hyperinflammation. So to treat that, we need anti-inflammatory treatment. And also, the patient with COVID-19 had um, um, some sort of the coagulation problem. We don't know for sure the mechanism for it, but for that, we are using the anti-coagulation treatment like a heparin. So talking about antivirals, now we have remdesivir, um, which has shown the decreased duration of the recovery compared to the placebo for 5 days. Although WHO is not recommending to use remdesivir, but I can understand why they say the WHO say because remdesivir is an injectional drug and it's quite expensive. So this drug has a potential issue of access to every part of the world, which is quite big actually from the viewpoint of the WHO. I can understand it. Otherwise, some blood products like a convalescent plasma and antibodies are quite promising, especially for the mild patients with high risk of getting severe progressing to severe COVID-19. Talking about anti-inflammatory drug, dexamethasone is quite famous. That is shown the effectiveness by the study by UK, but otherwise, as the dexamethasone cause very high blood glucose or some other complications, the companies and the governments and academia are trying to do some sort of investigation to find out what is more good, more safer anti-inflammatory drugs. So these are the landscape of the treatment for COVID-19. But now somehow in the very beginning, honestly speaking, we didn't know for sure what we can do. But after 10 months, we have somehow, we know the way to go. I mean, in terms of the treatment, which is very good. Alrighty. And there are some promising data coming from Japan. I can introduce you. One is the fit sat is the marker to predict that the patient will become severe or not. So this is one study from a young colleague at NCZM, and he's a nephrologist, and he was deeply involved in the blood perfusion therapy, blood purification therapy, and he found that the patient who developed severe COVID-19 had very high FABP and beta microglobulin in the urine, which is quite simple test, but this data is quite strong. So by utilizing this two kind of biomarker in the urine, we may be able to predict who's going to be the severe COVID-19, and we might be able to treat those patients like a preemptive manner. I mean, even before they develop the severe COVID-19. There are the other biomarkers like a CCL17, and if the patient has very low CCL17 in the very beginning, they are at high risk for developing quite severe COVID-19. And if talking about this interferon, actually, this is lambda 3, in the clinical course of COVID-19, the interferon lambda 3 will get higher before the exacerbation of COVID-19. So this CCL interferon gamma 3 may predict the who gonna really will get who is really getting worse in a short period. So by utilizing this kind of biomarker, we can predict who's going to be what, who's going to be severe COVID-19, which may be able to for us to do preemptive treatment to prevent the severe COVID-19. So this is my actual last slide. This is the number of the patients which we took care of in NCCM. In the first wave, we had a very hard time. We had admitted 47 patients at the time in the peak of the incidence of COVID-19, and at that point, we have intubated 8 patients in a hospital. Which was a quite severe stormy time for us and also the healthcare workers in Tokyo, but we somehow gone through it. On the second wave, the singles were better. We had less number of the patients and much less number of severe patients with severe COVID-19. Now we are in the middle of the third wave, and honestly speaking, we don't know for sure what happens, but I personally expect that probably we have more number, the larger number of severe cases in the third wave compared to the at least second wave, or could be a similar number of severe patients compared to the first wave in the third wave. But by decreasing the incidence of new cases of COVID-19, we can decrease the incidence of new, severe cases. That help the function of healthcare facility. So we hope to do the situation will be like that. Okay. So thank you very much for taking your time to listen to my presentation. Thank you so much.
Thank you very much, Dr. Ohmagari, for your comprehensive review about the burden of COVID-19 in Japan and significant changes in diagnosis and treatment in a very specific timeline during the first and the second wave in Japan. You also cover many aspects of COVID-19 from basic science to clinical application, and I hope the audience can follow and recognize that the Japanese scientists and doctors are very active to try to figure out the biomarker for predicting the severe case for effective intervention. Thank you very much.
Thank you.
Yeah. Could you please turn off the slide
Sure,
so we
sure.
can have a discussion from the group? I would like to receive some question or comment for Dr. Ohmagari's presentation. And in the meantime, my colleague, Dr. Do Dang An, please pick up some comment on the Facebook.
Facebook.
Yeah, or YouTube, yes. We hope that we have more interaction with
I see. That's good.
Yeah.
40.
Let me go to Facebook.
So I have a question concerning the severity of infection.
Okay.
I'm really surprised that the second wave, patient during the second wave have a better prognosis. Yeah, and I read some textbook, and it's usually say that during the pandemic, the later stage have a better prognosis. And do you think this is a common feature for other viral infection?
Well, actually, honestly speaking, this is my first time for me to take care of, to experience this kind of the very, so to speak, pandemic. But we are now witnessing that what is written in the paper, in the journal, and also textbook. It appears for us that definitely the outcome of the patient is improving, and which is probably because of the improved medical care, or probably improved explained by the earlier treatment. However, we don't know for sure. It's the interaction between virus and the immune system of us might be playing a major role. But I'm not, basic scientist, so someone among this audience will look into that. I hope that.
Yeah, thank you. Dr. Ang, do you receive any question from the audience?
It's not yet.
I see.
I would like to have some comment.
Can you turn on the video?
It is excellent presentation to get experience on the majority in the clinical management. But my question belong to the screening before hospital. I have heard that you apply some tests. There is like a rapid test at the airport.
Okay.
Also recognize the protein. So how about this useful for screening and sensitivity and specificity?
Thank you, Dr. New. A very nice question. And we have been struggling with that, honestly speaking. Well, talking about the symptomatic patients for COVID-19 talking about a patient with COVID-19, I think that, antigen test, rapid antigen test is quite useful. Although they are not so sensitive compared to the PCR testing, but it appears that this antigen testing will pick up the patients who have COVID-19, who may transmit diseases, who are in the phase of transmitting this virus to other people. So in the case of the symptomatic cases, I think it's quite useful because the other point is because it doesn't take time for us to do this test, just 30 minutes or less.
Yes, it's good. We also wish to have this in our country.
I see. But one thing is we have experienced is it it appears that maybe some percent, although it might be through very small fraction of the patients, but we have experienced some false positive cases, which caused some
Yeah,
sort of the confliction, on the ground. But we they may resolve it, I believe.
Vietnam also experienced on the two case phone positive. That means
Ah,
we inform the positive, but
mm,
actually it's negative.
I see, I
But
see.
that's alarming to the system. That is
Mm,
good.
mm, mm,
We have a positive point of view
mm,
to think about this.
mm.
The screening, the majority is sensitivity. Specificity might be lower,
Right.
doesn't, but we screen to catch all the cases. That
Mm,
is important for public health. Very good.
thank you. I agree.
I don't see any question on the chat book, so maybe we can continue and then we can go back.
Thank you. Thank you so much.
Yes, Dr. Ohmagari, I have one question.
Sure, sure, please.
Maybe not related to your lecture, but I think because your hospital is one of the major, very big hospital in Japan, but I'm in the like a local hospital, and we often deal with the problem of moving the patient or transfer them from the central hospital to the local one.
I see.
So yeah, very it's kind of traffic jam in the
Mm,
COVID-19, and I
mm,
want to know more about kind of strategy to stratify and to um, share the uh, hospital care or
mm,
maybe elderly care
mm.
in Japan.
Well, you know, uh, thank you, Dr. Kui. The similar situations, phenomenon is happening all over Japan. The big foster, the big hospital has been struggling with transfer of the patients with the, other hospital. And one thing is the talking about middle size, small size hospital. Basically the healthcare workers does not have enough, big experience of taking care of the patient with COVID-19. So as they don't have big experience, they are quite feared about it. I mean, as they don't know the detail about the COVID-19, they are just feared. But it's quite understandable. So that is a quite natural phenomenon for us to see what is the unknown, phenomenon. So probably we have to talk together to know about the COVID-19 itself, the clinical pictures, what is the infection prevention control practices. And the other thing is, um, I have I've heard more than a couple of opinions that although the government said that after 10 days from the onset of the symptom, the patient does not have infectivity to other people. However, is that true? That is the question. And
Yeah,
it's quite
maybe
understandable.
some
Yeah,
rare case is picked up on the
yeah,
mass media and make
right.
everybody worries about that.
Yeah, they know that. So probably when we transfer the patient to other hospital, the other hospital we need some sort of the infection prevention control, you know, for their safety and for their, to keep their, heart calm. So probably introducing very lighter way of, infection prevention control, very simple PPE into the not step down, but the hospital to be transferred will need it. But to do that, probably we have to talk together. And what kind of infection prevention control too in the second hospital?
Mhm.
Because in the second hospital, they just don't know what they can do for in terms of infection prevention control when they accommodate those patients from the bigger hospital. So probably we need a talk, we need a discussion.
Yeah,
And in the other parts of the world, in Japan, they are doing the similar things. But finally, they have resolved this kind of issues. So yeah, I hope that everybody will talk about it. That
yeah.
can resolve the issue. Yeah.
Actually, my major is related to oncology.
Oh,
So
you are okay.
yes,
Ah,
I always deal with many patients worries about fever when they have
I
a
see. I
raise in
see.
body temperature. It is COVID-19, and do we need to screen them or not? And
Ah,
so my concern is do the screening or precaution for COVID-19 may delay the normal treatment or normal care
I
of
see.
the other patients.
Ah, I
Yeah,
think I think you raise a very important point in terms of the care of the patients with non-COVID. I mean,
right.
in Japan and also in any other part of the world, because of COVID-19, the in general, medical care has been, how can I say, so had sort of some sort of the limitation, because of COVID-19, like a screening you mentioned. So I do understand what in that kind of situation. And actually, I was working in a cancer hospital previously.
Oh, yes,
I do know the situation. So I do
right.
think I do understand what is the situation. So
Yes.
yeah.
So I met some of my patients who really need to delay the operation because of
Ah,
just because of fever, and they want to rule out
mm,
COVID and wait for another 2 weeks before everything
ah,
come clearer.
I see.
So in some situations, the benefit of the patient
Mm,
is balanced to the benefit of the group or the public,
I
and
see.
this never happened before.
Right, right, right. Well, in the very beginning, we had a quite same thing in the hospital. But what resolved this issue is the introduction of new testing, like a PCR testing or rapid testing for that. Um, in the very beginning, it took time for us from the submission of the specimen to the lab to up until we obtain the result of it, like a 4 days or 5 days. But now it takes maybe 30 minutes or less, maybe
Mhm.
30 minutes to 1 hour. That may shorten the time for us to make a decision.
Yeah,
Yeah,
great. So innovation actually have to solve the problem.
yeah, I do. This time, I do think that I through going through this all COVID-19, now I do think that the innovation is quite important to make the situation change. Yeah,
Yes, thank you very much.
thank you.
So we're just talking about how to manage the hospital during the pandemic related to COVID-19.
We have a
And
sorry, from in the Q&A, we said that
Oh,
yeah, what's the challenge is that to vaccinate
ah,
vaccine in Japan? We have
ah,
what Japan's.
mm, thank you so much. Yeah, yeah. You know, vaccine. Okay. So one thing is, yeah, we don't know for sure we have enough number of vaccine. That is the first barrier. And the second barrier is, yeah, the people in Japan has phobia about vaccination because in our country, in the last 2 to 3 decades, there was at least 2 or 3 major, incidents. I mean, major accidents.
misunderstood
Right, right.
understanding.
Misunderstood the
Yeah.
effectiveness, and they have a belief that the vaccination is harmful for the health. And those kind of beliefs quite strong in our country. And it appears that the new vaccine, like from big pharma, appears to be quite effective. However, looking through the paper of the result of the study of the vaccine, it appears that they have high incidence of you know um, severe adverse events like a quite bad fever or quite severe pain. Um, so um, so if they do have such kind of high incidence of severe adverse events, I believe that that kind of vaccination may not be accepted in Japan, the society of Japan. That is my biggest concern. Mm.
And one more question
Mm.
for Dr. Omagi. Could you explain a bit about how hospitals in Japan prepare for response to COVID-19 outbreaks?
I see. Okay.
It's very late.
Yeah.
Second question, second presentation from Dr. New.
Yeah. This is very difficult. The most difficult part for us healthcare workers to run the hospital. One thing is some of the significant fraction of the patients are asymptomatic. So we cannot differentiate the patient has COVID-19 or not by a symptom itself. So what we are doing is the first thing is even though uh, the patient or healthcare worker who has symptoms, even though it might be very small, mild, they have to admit those symptoms to the colleagues or healthcare workers. By knowing that we can do some sort of the test for PCR testing for COVID-19, and we can at the same time we can start infection prevention control. And the second thing is some hospital wants to introduce PCR testing when they are accommodating new patients in the hospital. I mean, new admission in the hospital. Third thing is the universal masking. You know, because I may have COVID-19 and you may have COVID-19 even though we are asymptomatic. But everybody has a possibility, likelihood of having COVID-19. I mean the virus in the throat. So to prevent for us to transmit those viruses to other people, what we can do is wearing a mask, even though we are asymptomatic. So the hospital in Japan now, in the hospital in Japan, every healthcare workers are wearing a mask, and even the patient, inpatient and outpatient is wearing a mask, so that they will not present the virus to other people. So by those ways, we are coping with this issue of COVID-19.
Thank you very much. I learned that the Japanese healthcare worker is very careful, and there's a lot of they are dealing with a lot of stress because the manager asking them not to go out for drink.
Right.
Yeah, it's a stress because almost no party for the whole
Right.
1 year.
Right.
Yeah.
Right.
And
It's painful.
we have tried tele drink, but not so effective.
If the vaccine is effective, we might be able to do that in 1 year, but I don't know for sure. But
Yeah.
I believe that we need innovation, even though we are thinking about drinking or making a party.
Okay.
Some sort of innovation may create some new way of enjoying.
Yes.
Yeah.
So everybody, shall we move the stage to Vietnam and listen to some strategy or experience from Dr. Nhung in his hospital? Actually, I'm very impressed in a feature, actually a classification in Japan, where they stratify each prefecture into high risk or low risk of um, outbreak of COVID-19. And that is really practical because they take into account the limitation of the healthcare system. For example, in Okinawa, there's not so many ICU beds. So they raised the level of alarm in the very high from the beginning. So blocking
Right.
on the passenger from other prefecture.
Yeah.